Hi, everyone. Thank you for joining the IJGC Journal Club for the month of July. We're very, very pleased that you have joined us. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. Participants with the cameras turned on may appear in the video recording. And we ask that everyone please mute your microphone so everyone can hear the presentation and we don't have distraction in terms of sounds other than our speakers and our discussants. If you have any difficulties or questions, please send a message in chat and our technical support will assist you. So with that introduction, I wanted to introduce this month's lead article, which is titled Long-Term Survival Outcomes in high-risk endometrial cancer patients undergoing sentinel lymph node biopsy alone versus lymphadenectomy. The author of this manuscript is Vito Andrea Capozzi, who is from the University Hospital of Parma. And I'm very, very pleased to welcome Vito to our Journal Club. We certainly thank you for your time and thank you for submitting the article to our journal. He's going to give a brief presentation of the article, and then after that, we'll get on to some of our questions and further discussions. So thanks everyone for joining and welcome to our new fellows in the International Journal of Gynecological Cancer, who will also be participating in this journal club. So Vito, welcome and please proceed.
Thank you, Dr. Ramirez, for your hospitality, and thank you to everyone for taking part in this journal club. It's a great pleasure to be here with you, and I'm so proud to be able to discuss our article today with you all. I hope this journal club can be useful and enjoyable for everyone, so let's go. The title of our article is The Long-Term Survival Outcome in High-Risk Endometrial Cancer Patient Undergoing Sentinel Lymph Node Biopsy Alone versus lymphadenectomy. Okay, just a moment for the next slide. Okay, the background. We have the sentinel lymph node biopsy that was first introduced in 2014. The sentinel lymph node was a reliable technique for nodal staging and offers significant advantage in terms of reduced postoperative morbidity compared to the traditional lymphadenectomy. The CONSORT trial in 2008 and the AZTEC trial in 2009 both reported no survival benefit associated with lymphadenectomy in early stage endometrial cancer. Soliman et al., the SHREC trial, the CENTOS trial, explored the sentinel lymph node feasibility in high-risk endometrial cancer. This study showed a 95 to 98 sensitivity and a negative predictive value of 99% for sentinel lymph node biopsy in high-risk patients. Currently, limited data are available on survival outcome associated with the sentinel lymph node biopsy alone in high-risk patients. The current guidelines, the ESGO-ESP guidelines, recommend the sentinel lymph node as the preferred option for nodal staging in low-risk and intermediate-risk endometrial cancer. So the systematic lymphadenectomy, pelvic and aortic, is still recommended in high-risk patients due to the absence of long-term survival data for sentinel lymph node biopsy in high-risk endometrial cancer cases. The aim was to compare the long-term overall survival and disease-free survival of high-risk patients undergoing sentinel lymph node biopsy alone versus systematic lymphadenectomy. One moment for the next slide. Okay. A multicentric retrospective study on patients with high-risk endometrial cancer was conducted between January 2007 and December 2019. All patients underwent the recommended preoperative workup, surgical treatment, adjuvant treatment, and the follow-up at the time of diagnosis. In case of sentinel lymph node mapping, the Memorial Sloan Kettering Cancer Center algorithm was applied for cervical injection, so we used the ICG. All patients in the lymphadenectomy group performed systematic pelvic lymphadenectomy and, in selected cases, aortic lymphadenectomy up to the level of the left renal vein. Patients who underwent site-specific lymphadenectomy in case of unilateral sentinel lymph node failure were excluded from the analysis. Patients were allocated in two groups depending on the type of nodal surgical staging. Sentinel lymph node biopsy alone was the group 1, and lymphadenectomy was the group 2. The primary aim was to compare the long-term overall survival and disease-free survival of high-risk patients undergoing sentinel lymph node biopsy alone versus systematic lymphadenectomy. The secondary objective was to identify the predictive factor for occurrence of surgical complication in the two groups. Finally, a supplementary post-hoc survival analysis of cases with nodal metastasis was performed to compare sentinel lymph node and the lymphadenectomy survival outcome in this subset of patients. 237 high-risk patients were included. 115 patients underwent sentinel lymph node biopsy alone. The median follow-up was 31 months with an interquartile range 18 to 40 months. Overall and disease-free survival were not statistically different between the two groups. Even in patients with nodal metastasis, sentinel lymph node showed superimposable disease-free survival and overall survival compared to systematic lymphadenectomy. 38 total recurrences were observed, 14 nodal recurrences were identified, 4 in the sentinel lymph node alone group, and 10 in the lymphadenectomy group. Tumor grade and FIGO stage were independently associated with the risk of recurrence. 20 complications occurred, 7 in the sentinel lymph node alone group and 13 in the lymphadenectomy group. Body mass index was the only significant risk factor associated with complication. The main findings were sentinel lymph node mapping alone in high-risk endometrial cancer appeared to be an oncologically safe technique over a long observational time, and the systematic lymphadenectomy in this population would not affect survival even in histologically confirmed nodal metastasis. This is the visual abstract. Thank you.
Well, Vito, thank you so much for that presentation, and I think certainly a very relevant topic because, as we know and as you mentioned, there are a number of centers and of course, obviously also surgeons who absolutely are very accepting of the concept of sentinel lymph nodes alone for low-risk patients. But you still hear many surgeons suggesting that for the high-risk patients, they still have to do a lymphadenectomy, and because there's concern that we're not going to be able to detect metastases if there truly are metastases. But it seems that there's an increasing number of manuscripts and data supporting the fact that it's not just for low risk, but also for high-risk patients, that it is okay, that it is safe to doing a sentinel lymph node alone and not a lymphadenectomy. And as you know, and we all know, and we've seen, many times you still see videos being submitted of these like massive lymphadenectomies in the pelvis and the periodic. So I think this is a great opportunity for us to open up the discussion. And thank you again for that presentation. Really very important information and an excellent topic. So we will start. There are some questions already being submitted in the chat, and definitely we welcome as many questions as you might have. But we'll start with one of the questions from our fellows, Dr. Guido Rey Valzacchi from Argentina, Buenos Aires, Argentina. So Guido, what is your question?
Hello, everybody. Well, my question is related to the lymphadenectomy. In case one chooses to do a systematic lymphadenectomy, or in which cases one would do a para-aortic lymphadenectomy, or just the question can be in which cases one would choose to do a para-aortic lymphadenectomy. I mean, perhaps one can choose to do the sentinel lymph node, and if it doesn't map, you do the systematic lymphadenectomy. But in which cases one would consider to do it in the para-aortic area too?
Thank you, Dr. Valzacchi. Current guidelines recommended pelvic lymphadenectomy for high intermediate risk and high risk patients. Furthermore, when systematic pelvic lymph node dissection is indicated, the aortic lymph node dissection should also be performed. Therefore, every time we perform the pelvic lymphadenectomy, we should perform an aortic lymphadenectomy. On the other hand, current data on sentinel lymph node occurrence in nodal metastases show that sentinel lymph node could be a available alternative also for high-risk patients. So in my personal opinion, at the moment, we have to stick to the guidelines. So when we have to perform a pelvic lymphadenectomy, we should perform aortic lymphadenectomy. But it's reasonable to think that in the future, only in selected cases, such as in cases of bulky lymph node, we will perform an aortic lymph node dissection. But at the moment, we have to follow the guidelines. So when we have to perform a pelvic lymphadenectomy, we have to do an aortic dissection.
Yeah, I mean, it's an interesting question that is still ongoing, and I think, you know, Guido, there are many who would argue that there is enough data to support that the isolated para-aortic lymph nodes are really extremely rare, and that therefore by just doing a pelvic lymphadenectomy, one should already have enough information, meaning that if you do a lymphadenectomy in the pelvis and you don't find any positive lymph nodes, the likelihood that you're going to have a positive para-aortic is going to be very low. And in addition to that, the question of like the extended field radiation to the para-aortics, a lot of the data on that was from the time when we didn't use chemoradiation for positive nodes in the setting of endometrial cancer. So I think it's a very good question, a valid question, and one that is still being debated. We're going to go to some of the questions from the chat. And one question, the first question is from the Pali Raina, and she's asking how many patients were node positive overall in both groups. I don't know, Vito, if you have that information right away, but you know, certainly if you don't, then we can refer the question for evaluation of the manuscript itself. The other question comes from what is the mean number of lymph nodes removed in the lymphadenectomy group? You know, I would actually open up that question for further discussion. Doesn't matter. Does it really matter if the mean number is 10 or 12 or 13 or 15 or 20 or 5? If you have sentinel lymph node mapping and one is suggesting that there is no need for lymphadenectomy, then does that number matter? Vito, what are your thoughts on the number of lymph nodes?
Yes, the median number of lymph nodes removed in our cases was 14. I completely agree with you on the number of lymph nodes removed. In the literature, we can find a big range of nodes removed to consider the lymphadenectomy as systematic. Can range from 10 to 30 lymph nodes to consider to define a lymphadenectomy as systematic. I think that the number of lymph nodes removed varies enormously depending on patient anatomy, BMI, and also the pathologist patient to count lymph node. I don't know if you ever read something of the LODS. The LODS is a odds of positive lymph nodes. It's the ratio between the positive and negative node instead of the total number of the node excised. This exists for this reason. Concerning the indication and extension of the systematic lymphadenectomy, we used the traditional boundaries for the pelvic and for the aortic lymphadenectomy. In our cases, in our center, aortic lymphadenectomy was performed in case of bulky nodes at preoperative or intraoperative evaluation. So I agree with you. The number of lymph nodes maybe it's not really important to consider lymphadenectomy as systematic, but it's more important to see all the surgical field, to remove the suspected or bulky nodes, and then to decide if performed also an aortic lymphadenectomy or not.
Great, thank you, Vito. And I think the next question was from Giuseppe Caruso, but I think Vito somewhat addressed it. Giuseppe, do you have any follow-up comments to Vito's answer as it pertains to the grade of the tumor and the extent of lymphadenectomy?
Yeah, hi everyone, and thank you, Vito, for this great presentation. This is a very interesting topic. You covered one of my questions that I had about lymphadenectomy, but I wanted to ask you more about the tumor grade and the FIGO stage, because you reported that these two variables were negative independent prognostic factor, but these two variables were imbalanced between the two groups, the sentinel lymph node and lymphadenectomy, because there were like more grade 2, 3 tumors and advanced stages in the lymphadenectomy group. So I wanted to ask you if you think that this introduces a big bias in the interpretation of the results.
Thank you, Giuseppe, for your question. As you mentioned, we found that low-grade histology was more represented in the sentinel lymph node group. However, this difference was not statistically different because we found a P of 0.058, and the imbalance of the FIGO stage was expected, both for the exclusion of patients with the suspected preoperative bulky lymph node from the sentinel lymph node group, and then for the aortic lymphadenectomies that, of course, we performed only in the lymphadenectomy group. However, tumor grade and FIGO stage were independent prognostic factor linked to the risk of recurrence in the total population, including both groups, the sentinel lymph node and the lymphadenectomy groups. Therefore, the imbalance in the two groups did not influence the result of this kind of analysis.
Excellent. Well, thank you, Vito, for that response. And I think now the next question deals with the type of metastases that you actually find in the sentinel lymph nodes, and always obviously a concern, particularly when you're looking at high-risk patients. So next question is from Luigi De Vitis, who will ask about this particular topic.
Hi, everyone, and thank you, Vito, for your article and your presentation. As Dr. Amir said, my question is on isolated tumor cells. So as the number of sentinel lymph node procedures is increasing, we will expect a higher number of isolated tumor cells, findings of isolated tumor cells. So my question is, do you think that isolated tumor cells in this population should influence the type of adjuvant treatment? And then in general, I would like to know, how do you manage ITC in your center? Thank you.
Thank you, Luigi. The guidelines consider ITC not influence the adjuvant treatment. ITC detection in endometrial cancer patients does not seem to have impact on survival outcomes and don't influence the adjuvant treatment in high-risk endometrial cancer patients also. So at the present in our center, we follow the guidelines. So the presence of ITC is managed as N0, and the prognostic risk is estimated depending on remaining pathologic and molecular risk factors. So this is a really interesting question, but at the moment, we don't have the number of ITC in high-risk endometrial cancer patients, and maybe this aspect can be analyzed in the future, of course, but we can think that or expected that the ITC will not influence the adjuvant treatment also in high-risk endometrial cancer patients as in the low-risk patients. This is my opinion.
Yes, and I thank you, Luigi, for asking that, because I think that for most practitioners, a single ITC is not going to be so concerning. But I think that is when you start getting these reports where you have multiple sentinel lymph nodes, with each one having isolated tumor cells, particularly also if you have bilateral isolated tumor cells. And then you start wondering, well, is this patient really deserving of additional treatment or not? And I think it's always a question of debate. I see Nicolo Bizzarri on the call. Nico, how are you? What do they do at Gemelli with isolated tumor cells for high-risk patients?
Thank you, Pedro, and congratulations to Vito for the great article I read with great interest, and for the Journal Club. At Gemelli, we do not treat isolated tumor cells. Of course, the occasion of having more than one lymph node with tumor with ITC is quite rare, and to my knowledge, I don't remember how this was treated, but in general, ITC just undergo follow-up. Thank you.
Excellent. Thank you, Nicolo. The next question is, I see Alessandro Buda from north of Italy, in Piemonte. I see that we're very popular today, this journal club in Italy. So Vito, thank you so much for bringing in all the crowds in Italian. This one is from Alessandro Buda. Alessandro, I don't know if you want to ask the question yourself or if you want me to ask. If you're on the call, please go ahead and ask. Let's see, maybe Alessandro is jumping onto the audio, but I'll start with a question. It says, comparing women with stage 3C in the sentinel lymph node biopsy and the lymphadenectomy subgroups that are different is like comparing apples and oranges. In fact, positive sentinel lymph node discovered by ultra staging, including micrometastases or isolated tumor cell, can be considered stage 3C by accident. Lymphadenectomy group have bulky lymph nodes or microscopic metastases discovered pre or intra-op. How did you select women in the pre-op workup for determining sentinel lymph nodes versus lymphadenectomy? So is there anything in the pre-op that makes you consider one or the other?
Okay. No, I'm not completely agree with Dr. Buda, because of the ITC can be considered 3C. So he talk of accident 3C. Anyway, the selection of the patients is not completely correct, because this is a retrospective study. So we have an inclusion criteria. We don't have performed any selection of patients. Anyway, central lymph node was applied in accordance with the guidelines at the moments of the surgery. So any suspected lymph node at preoperative workup, that means maximum diameter of more than 10 millimeters were considered as suspected lymph node. So in these cases, we excluded the sentinel lymph node dissection, the sentinel lymph node mapping. This study so considered these two groups that have the metastasis, nodal metastasis. So the subgroup analysis was performed to overcome this problem. The main question when we performed this analysis was is different to remove one lymph node compared to all lymph node, also in high-risk patients. In the past, we have seen that this aspect was not different in early stage or low risk patients. So we can expect that, and we expect that in the future, this difference was not found also in high risk endometrial cancer patients. So to answer to Dr. Buda, we have a retrospective study. We have a 3C figure stage patient. One patient in one group performed only sentinel lymph node biopsy alone. On the other hand, we have a systematic lymphadenectomy. So what we have to consider, considered was the survival outcome with a really long observational time. So I have underlined the interquartile range. That means that the 75% of all patients were followed for almost 18 months to 40 months. So is the biggest observational time that we have found in our knowledge in the literature. So This is the study, but of course have a limitation. Of course, we don't have selection of patients. So of course, maybe some ITC were considered accident 3C, but this aspect happens everywhere, every time, in every study. So this is my opinion.
Pedro,
Thank
Pedro,
you,
can I say something? Can I say something?
Oh, Alessandro Buda has picked
Yes.
up the microphone, a
Yes.
rebuttal.
Yeah, no problem. I think the question, it's okay for Vito what you said, but you didn't understand my question. The 3C in the sentinel lymph node group alone is by accident, because usually you can consider this at low risk patient, subgroup of patient science. If we found for the, thanks to ultra staging, we can find usually micrometastasis or ITC. From vice versa, in the subgroup of lymphadenectomy, however you work up the patient. For example, we use PET-CC to find, or the algorithm sentinel lymph node and PET scan, or we can say also today radiomics to say, okay, we don't have any suspicion node in the pelvis or in the aortic, and we can go for sentinel. Somehow you can, in the subgroup of, vice versa, in the subgroup of lymphadenectomy, usually we found or bulky nodes, because we go for pelvic and aortic lymphadenectomy, or macrometastasis. So when you go to see the analysis of survival, you can't compare these two groups and you can say, okay, these are the same group of women, because from one side you have low risk patients. By accident, you find, thanks to ultra staging, ITC, we don't know how to treat this, or micrometastasis. In the other group, you have usually macrometastasis. So this is another type of group of women with another risk of recurrence. And so this is the drawback, I think, of my study, of your study, and all the respective studies. So if you want to compare sentinel node and lymphadenectomy, you have to perform a prospective trial where you have the same subgroup of women with the same risk to find the same rate of metastasis, I mean, low volume or macrometastasis. This is the heart or the question, because the retrospective analysis, if you look at your postdoc, for example, you found a difference, but it wasn't statistically significant.
Yes. No, thank you for that comment. And
I hope you understand.
Yeah,
we can compare these two groups because, you know, so it's somehow statistically not very good.
Yes. So again, actually, that brings us to the topic of the next question with regards to, you know, you call for a prospective study with regards to the event rates. In other words, in endometrial cancer, when you have a disease that may not have so many recurrences. And this question comes from Matt in Wisconsin in the United States, one of our incoming fellows as well. Matt, you want to go ahead and ask your question?
Sure. Thank you. Hi, Dr. Capozzi. Thanks for coming. So as Dr. Ramirez alluded to, you know, the rate of recurrence in this cohort that was reported was overall very low for a high-risk patient population. Do you think that this could raise concerns that there could be an effect that's not detected here in favor of performing complete lymphadenectomy, given that low rate of recurrence that was noted in the study?
Question.
Thank you, Dr. Wagar. The recurrence rate reported in our study is actually lower than the reported in the literature. However, we have to consider that all the patients, including the analysis, were treated in gynecological cancer referral center. Those they were all adequately staged with preoperative imaging, underwent a complete surgical treatment with experienced surgeon, and finally adjuvant treatment was administered in line with international guidelines and recommendations. However, we cannot underestimate the fact that our study is a retrospective analysis that we did not complete the 5-year surveillance for all the patients. Besides, the selection of early stage patients at preoperative imaging in the sentinel lymph node group may have influenced our results. So in conclusion, we are agreed that our recurrence rate was lower because we reported a 15% and almost 15% of recurrence, but in the literature, we can find also a 30% of recurrence in these patients. So in conclusion, we need a randomized clinical trial to answer, to give the right answer to this question.
Excellent. And now we get into the topic of uterine risk factors, and we'll go to Jorge Hagel in Caracas, Venezuela.
Hello, everyone. How are you? Thank you, Dr. Capozzi, and congratulations for your presentation. So my question is about lymphovascular space invasion. And being this retrospective multicenter research, can you explain how you standardize the measurement of lymphovascular space invasion for this article? You know, this is sometimes a polemic topic, and some pathologists made his measurement in one way and others in another way. And how you standardize that for this research?
Okay, thank you, Dr. Hagel. In our department and in the unit of the whole center involved in the study, we have a dedicated pathologist in gynecology oncology. The lymphovascular space invasion is defined as the presence of tumor emboli into the vascular space, and the lymphovascular space invasion has an impact on prognosis and on adjuvant treatment. So only when it is substantial. So the substantial LVSI is defined as the presence of lymphovascular invasion in at least 5 vessels on hematoxylin eosin slice. So LVSI also in our study was considered as positive when reported as substantial by the local dedicated pathologist.
Yes, and I just wanted to add, I think that lymphovascular space invasion by itself, I don't think that anybody would look at that as a unique indication for adjuvant treatment in the setting of endometrial cancer at this point. The next question comes from Seda Sahin Akar. She's in Turkey, and she wants to ask about, I believe, location of sentinel lymph nodes.
Thank you, Dr. Capozzi, for this great presentation. I want to ask that, did you routinely evaluate the presacral sentinel lymph nodes, or did you just focus on the pelvic sentinel lymph nodes? And another question, is there any difference in overall survival and recurrence in the subgroup analysis at earlier stage 1 and stage 2?
Thank you, Seda. In our institution, we not routinely excise presacral lymph node for sentinel lymph node mapping. And when we found an external or an obturator sentinel lymph node, we considered the biopsy to be sufficient for staging purpose. When in case of failed mapping, we consider reinjection, and then the dissection of less frequent or atypical sentinel lymph node site, as in case of presacral area. For the second question, we did not conduct a subgroup analysis for high-risk endometrial cancer patients in only early stage, so in stage 1 and 2. So further observation and analysis should be conducted to answer to this question.
Excellent. So we'll go back to some of the questions on the chat, and of course, obviously, this question is always going to come up now. With regards to molecular factors and molecular profiling and how this is going to impact surgery in the future. And the question relates to, if you already know that a patient has pre-op factors that are high risk, or a molecular profiling on that tumor that you know is going to require adjuvant treatment, like P53 positive biopsy, doesn't matter whether you do lymphadenectomy, whether you do sentinel lymph nodes. If you already know, you're going to treat this patient.
Yes, at the moment, we have to follow the guidelines. So in these cases, systematic lymphadenectomy should be performed. Maybe in the future, the molecular classification can help to give the surgeon to decide if perform a sentinel lymph node or lymphadenectomy. I don't know, but I'm really interested in this question, and in my opinion, my personal opinion, the molecular pattern of the patient will guide the surgeon. So in cases of P53 patients, maybe the lymphadenectomy should be performed.
Yes. And I think obviously there's still ongoing evaluation of this question of the role of lymph node evaluation at all. As you know, there's the ENDO-3 study by Andreas Obermeyer's, an international multi-institutional study that is looking at endometrial cancer patients who are randomized to sentinel lymph node biopsy alone or no lymph node assessment at all, no lymphadenectomy, no sentinel lymph node, just hysterectomy, and then following with adjuvant treatment. So that'll hopefully offer additional information regarding whether we need to even do a mapping evaluation of the sentinel lymph nodes, and that study, of course, is ongoing. Let's see. Yes. Is there a question from the audience that I hear?
No, I just said thank you for answering my question.
Thank you for posing the question. Okay, now I think the next question comes from Jessica Mauro. I don't know if Jessica it's with us.
Yes, I'm here.
Hi, Jessica.
Hi. Excuse me, but my camera doesn't work today.
It's okay.
So thank you, Dr. Capozzi. My question is about the choice for adjuvant treatment. So did you choose adjuvant treatment based on nodal status or rather on the tumor's own risk factors, considering also the current molecular classification?
Thank you, Jessica. In our study, patients were considered eligible for adjuvant treatment according to the pathological factor of the uterus, so the non-endometrioid histology, high grade, the presence of endometrial infiltration, etc. In our study, the study period ranged from 2007 to 2019, and the molecular classification was implemented in adjuvant treatment only in 2020. So in our study, the molecular classification did not influence adjuvant treatment in our institution.
Okay, thank you.
Fantastic, very well. And we have a question now from Giuseppe Cucinella. Now, I'm not sure, I don't know if Giuseppe's audio is functioning, but he submitted a question, Vito, and he's asking, considering these findings, are we still considering the sentinel lymph node as an alternative? Or could we just change the guidelines to say that it is a first option? So in other words, why do we keep putting lymphadenectomy in the guidelines and not just go straight to sentinel lymph nodes should be the approach?
Okay, this is a really important question and point to underline. Through a retrospective study, we can't show the safety, effectiveness, or we can't change the guidelines. So our study, the intent of our study was to see what happens at these patients. So these results can encourage the future research and maybe can suggest what will happen in the future after the ALES trial will show its result. So to answer to Giuseppe, I tell him that at the moment we have to follow the guidelines. So the sentinel lymph node could be considered an alternative, but the primary treatment and surgical stage for these patients remains the systematic lymphadenectomy.
So Vito, I'm going to put you a little bit on the spot. If you have a patient that comes to you and says, do you really mean that if I have a papillary serous carcinoma and you find one sentinel lymph node on the right and one sentinel lymph node on the left, Are you telling me that I am appropriately staged?
In my personal opinion, yes. In my personal opinion, yes. All the data of the past tell us that the accuracy of the sentinel lymph node was really high. So if we don't see any bulky lymph node that can't respond to radiotherapy or only if I don't see any other aspect, pathologic aspect, I can consider, in my opinion, we can consider these patients properly staged.
Okay. Second question, what would you say to a surgeon that comes to you after having done a staging for endometrial cancer with a beautiful video of this extensive pelvic and para-aortic lymphadenectomy and says, look, I received a pathology report and I have 65 negative lymph nodes. Isn't this surgery amazing and beautiful? And isn't it wonderful for me as a surgeon?
No, for me not. For me, it was the wrong way to see our job. In my personal opinion, it's not needed an extensive surgery in endometrial cancer, and in the future, maybe the young doctor like me or the young surgeon like me, maybe we will perform more or less lymphadenectomy. So I strongly believe in the central lymph node and the ultra staging, and I don't believe that remove all the presacral lymph node are useful for the patients. We have to understand also the morbidity of this procedure for the patients, so the lymphedema of the lower limb really damage the quality of life of the patient. So this is an important aspect that we have to consider if we want to treat in the good way patients.
And Vito, I have just one additional question for you, and I'd love to hear anybody else who is at a point of training fellows or resident. What about if you have a resident or a fellow that comes to you and says, hey, I saw your paper and I listened to your journal club and I get it. You don't want to do any more lymphadenectomies, but how am I going to learn to do a para-aortic lymphadenectomy all the way up to the renals?
All the young doctor like me want to learn how to do or perform this kind of procedure that are really hard to perform. But I think that the good mentor like me in Parma tell us that we have to do what is needed for the patient. So yes, it's beautiful to see video or extreme surgery, okay, but it's not the good way for me.
Vito, I think with that answer, you earned the respect of a lot of people who didn't know you before. I think it's exactly right to do what is best for the patient always. I don't see any more questions in the chat. We're coming up to the 45 minutes. We want to be obviously respectful of Vito's time, but are there any other questions, pressing questions from our fellows or from anyone in the audience? All right. Well, Vito, thank you so much. Fantastic Journal Club, really great. Thank you for your time. Thank you for sending your work to our journal. And thank you for obviously answering questions for 45 minutes straight. So go enjoy and have a good glass of wine.
Thank you, Dr. Ramirez. Thank you to everyone. I hope this Journal Club was enjoyed for everyone, and let's see for the next time.
Excellent. No, I also want to invite everyone to join us. It's going to be fairly soon. It's the August 3rd lead article Journal Club in August. It's prognostic factors in patients with endometrial cancer with isolated lymphatic recurrence. And this is going to be by Ilaria Capasso and Andrea Mariani. And we look forward to seeing you there. So thank you very, very much.
Okay. It was good, Dr. Ramirez.
It was excellent. You did a fantastic job. Thank you so much. Thank you to all the fellows who sent in their questions. And thank you for the former fellows that I see a lot of the former fellows present as well. So all of you, thank you once again.
Thank you.
All right.
Bye.
Take care. Bye.
Thank you. Bye.
Bye.